She is a board-certified dermatologist and pediatric dermatologist. She graduated from Tulane University School of Medicine in New Orleans.
Okay, down
and
forward.
Internship at Mayo Clinic in Scottsdale, Arizona, and went on to complete her dermatology residency
sure, maybe just in
at
case.
Mayo Clinic in Rochester, Minnesota. After she completed her fellowship in pediatric dermatology at Phoenix Children's Hospital in Arizona, she practiced for a decade in Colorado and moved to Boise in 2020.
Thank you.
To become our first and only pediatric dermatologist in the state of Idaho.
Whoop, whoop. Oh, you're welcome.
She works in private practice at Ada West Dermatology and is on staff at St. Luke's Children's Hospital, where she consults and performs procedures. She is also actively engaged in our advocacy side for the Idaho Medical Association. Was recently appointed as a board of trustee for District 4, in addition to Dr. Munn, she's here.
Hi.
Let's give her a big welcome, Dr. Lisa Swanson.
Hello. Hi, everybody. Isn't this place fantastic? You know, I've been in Idaho for 2.5 years. I've been to McCall about 12 times. I love it up here, and I specifically love the Shore Lodge. It's like one of my favorite places ever. I'm thrilled to be here. I included my email address at the beginning and at the end of my talk. I am more than happy to be your peds derm and derm phone a friend. You know, I'm the only one in the state, but I am always on my email, except when I'm planning to go to bed, right? Because I've learned about sleep hygiene, and so I give myself 30 minutes to watch Golden Girls before I go to bed. But please reach out. So many things can be solved with just an email to me with a picture, and it can save the patient a whole lot of time and hassle. That's the cool thing about dermatology. I always like to open my presentations with a story, and one of my favorite stories is about my dad. So my dad is a very recently retired urologist, and my mom gives him an F in retirement so far. She's not pleased with his performance during retirement. But my very first job growing up was working for my dad. I was like 14, 15 years old. This was before the internet. This was before, you know, PubMed, before UpToDate. And my dad would tear out articles in urology journals that he found interesting, and he'd write keywords on them, and it was my job to enter them into a database. So like author, title, keyword, so that he could find them later when he was going to put together a talk or things like that. And I'll remind you guys, these are urology articles, a lot of which that had pictures of urology problems. So I'm 14, 15 years old, kind of looking through these things like, oh my God, what does my dad do? You know? And so I would ask him, Dad, why on earth did you choose urology? This stuff seems real gross. And I grew up with my dad telling me, Lisa, there are two kinds of doctors, urologists, and those who wish they were urologists. And I'm like, Dad, I think that's not true. And I feel like I've seen enough evidence to say with confidence that's not true. Why on earth did you choose urology? And he said, well, Lise, it's because I can fix it. And that really resonated with me. And that's part of the reason I wanted to be a doctor, and part of the reason I chose dermatology, and specifically pediatric dermatology, so that there are so many ways that we can help fix our patients. And I'm hoping my presentation today helps you guys fix some of your patients as well. My gleam is peds derm, but I created this talk so that it's applicable to adults as well. So I think everybody will get something out of it, and I hope you do. These are my disclosures. I've been a speaker for several companies. Happy to break it down, what medicines I talk about today, go with which medicine, with which company. Happy to break that down for you. I'm hiding nothing, but those are my disclosures. So let's go into atopic dermatitis, something I spend about 25% of my day doing. What we're learning is that early baby life matters when it comes to atopic dermatitis. We don't have all the pieces to the puzzle, but we're getting there. So we know that early antibiotic exposure, especially at week 2, actually decreases the risk for atopic dermatitis. We know that transepidermal water loss in early life leads to increased atopic dermatitis. This was based on studies done using Vaseline as an emollient starting day 1 of life in babies predisposed to atopic dermatitis. And the first study showed a reduction in risk by about 50%. And the second study said, no, that's not true, there's no difference. And the third study said, yes, we can reduce eczema by recommending good sensitive skincare to babies starting day 1 of life. The microbiome. We know that if a pregnant woman takes oral probiotics a month before she has the baby to 3 months after she has the baby and she breastfeeds, it reduces the risk of eczema in that baby by 20 to 30%. So if I'm seeing a toddler, a 2 to 3 year old, and I can tell mom is clearly pregnant, that's important. You don't want to put your foot in your mouth, clearly pregnant. I'll say, oh, there are a couple ways you can help prevent atopic dermatitis in baby number 2. Oh yeah, of course. Oh, okay, perfect, okay. And so I will chime in and tell them that. The time spent in the NICU. So a longer stay in the NICU actually decreases your risk for atopic dermatitis. So all of this stuff is very interesting. It's not giving us a whole lot of helpful advice to tell people besides emollients and maybe probiotics for a pregnant woman, but we're not going to keep babies in NICUs. We're not going to give them all oral antibiotics, but we're getting pieces to the puzzle that are going to help us develop those strategies to avoid atopic dermatitis, which is exciting. The relationship between atopic dermatitis and food allergy has oscillated dramatically over the years. I think we can feel quite confident that we understand this relationship much better now than we used to. So food allergy and foods does not cause atopic dermatitis. It is rarely a contributing factor to atopic dermatitis. And we know that avoidance of food actually increases your risk for food allergy. So no baby and no mom who's breastfeeding needs to be on a restrictive diet because their baby has eczema. It's not going to help, and it could do harm with growth and with increased risk of food allergies. This is the pivotal article on the topic. I printed out several copies that I have in my clinic to hand to moms and families that are wondering and wanting more information. This article is definitely accessible to you guys as well if you ever want something to back up that knowledge. So growing evidence that food allergies might actually be caused by the atopic dermatitis. The theory being that the broken skin barrier allows aerosolized food particles to enter the skin where it triggers an abnormal immune system response, which represents allergy. And so the best thing you can really do to mitigate the risk of food allergy is treat your patient's eczema. And like I alluded to before, avoiding foods can be harmful. We don't recommend that. If you're concerned about a patient and food allergy, have them see the allergist. They can talk about how to introduce the food at an early age. So we think that eczema leads to food allergy. So they did a study in Japan where they took a bunch of kids with eczema and they treated half of them and they didn't treat half of them. Don't know how they got that approved by the IRB, but they did. And the risk of food allergy in the treated group was 75% lower. So the best thing you can do to prevent food allergy is treat a baby's atopic dermatitis. Sometimes when I'm talking to patients and their families about atopic dermatitis, I think of Leslie Knope when she's trying to convince the city of Pawnee that they don't need buckets of sugary sodas. And she says, all I have on my side is facts and science. And people hate facts and science. I think we've learned this especially during the COVID pandemic. But everybody wants natural therapies, particularly for atopic dermatitis. The bothersome thing is that not a lot of these things get studied. And so it's hard as medical professionals to stake a claim that something natural is going to help when you haven't seen a study to show that it's going to help. But a few things have been studied. Olive oil has been studied and was found to worsen eczema. It should be avoided. CBD, the jury is still out, but preliminary evidence says it probably has some benefit for itch and maybe even some anti-inflammatory benefit. There is a brand created with the help of a pediatric dermatologist in Chicago that doesn't contain a bunch of other bad stuff, and it's called Sequel, and you can buy it online. I have no vested interest. Coconut oil has good antibacterial properties, but doesn't seem to be pro or con for the eczema. So if people like it, go for it, but it doesn't seem overwhelmingly positive. Sunflower seed oil actually does appear to help with eczema, but it's difficult to find a good preparation that doesn't have a whole bunch of other junk in it. And so that's the big hang up there. There is an apothecary shop in Chicago that I'll sometimes refer families to. You don't need a prescription or anything. It's all over the counter stuff, and it's called Aroma Workshop. It's in Chicago. They mail it to the family. They make a sunflower seed oil that comes in a spray bottle, which is pretty nice. The impact of atopic dermatitis is huge. And I think just in the past 5 years, we've really begun to understand this. And while it's true that a good percentage of kids with atopic dermatitis will eventually outgrow it, There are ramifications and complications and implications of having atopic dermatitis, and so still important to treat it, even if their future is that they're going to outgrow it. We see increased rates of ADHD, anxiety, depression. We'll talk about more of that in just a second. Increased risk of the atopic comorbidities, asthma, allergies, EOE, increased risk of eye issues, increased rates of cardiovascular disease, osteoporosis, osteopenia, fractures. We'll talk a little bit more about that in a minute. Increased risk of infections is well documented, and the long-term consequences of perpetual topical and sometimes systemic steroids. There's also an increased risk of learning disabilities that's been well documented, and we'll talk about that in just a moment too. So atopic dermatitis and sleep, which segues nicely from our previous presenter. Studies show that parents of children with atopic dermatitis lose an average of 1 to 1.5 hours of sleep every night. I don't know about you guys, but I would not be very pleasant to be around if I was losing an hour to an hour and a half of sleep every night. This is a big problem with our patients and families dealing with atopic dermatitis. Also, even when kids with atopic dermatitis do sleep, studies show they don't sleep as well. They don't enter REM sleep as long or as often, and it's during REM sleep that growth hormone is secreted. So physiologically, these kids are getting less growth hormone. You may notice that kids with bad atopic dermatitis are small on the growth curves. This is why. We have a physiologic reason why, and it goes down to sleep and itch. IL-4 and the developing brain. So there are two cytokines that play a really pivotal role in atopic dermatitis, IL-4 and IL-13. And we've noticed for years that kids with bad atopic dermatitis have increased rates of autism, anxiety, depression, learning disabilities. And there was this study published in our Peds Derm Journal a year and a half ago showing that excess IL-4 could be the culprit. So they did studies in mouse models and found that IL-4 reduces myelination, leads to cognitive impairment and developmental delays. We might have our link here. And we now have a drug approved down to the age of 6 months that inhibits IL-4 and IL-13. And I have personally seen dramatic changes in behaviors like ADHD in patients treated with that drug, which we'll talk about. When I see patients with atopic dermatitis, I explain that eczema is caused by two things. Neither one is gluten. The first is skin barrier dysfunction. Our skin is our barrier, and in kids and people with eczema, their barrier is broken to some degree, makes them more predisposed to dryness and irritation from things. The second part of eczema is this inflammatory response that's unchecked and out of control. And so I explain we need to do things that protect our skin barrier, and then we need to treat the overactive inflammatory process. And so for barrier function, we do sensitive skincare. And I created my favorite things list. You guys can steal it. You can have it, doesn't matter. But I found it has saved me so much time because I just check off what's applicable to the patient that I'm seeing. And then they get a list of products that are safe to use and they're on their way. I bet you guys have heard of most of the things in the sensitive skincare section. The only exception might be the Robuthol bath oil. So anybody here heard of Robuthol? No. So Robuthol is made by Vanicream. It's made by the Vanicream people, and it's based in cottonseed oil, and you add it to bath water. If you're a shower person, you can pour it into a spray bottle, spritz in the shower with it. It will make you slippery, so be mindful of that when you go to get out or when you're grabbing your baby from the tub. But it's a very easy thing to do that can impact the moisture in your skin, and it appeals to those granola people from the North End, which is nice. They're all from the North End. They are. The Aaron regimen is my secret sauce. You guys are about to get some very secret information here. So the Aaron regimen, anybody here heard of it? Yes. Did I treat one of your patients?
My granddaughter.
Oh!
My daughter loves you and my granddaughter loves you.
There you go. That's the Aaron regimen in real life. Yeah. So the Aaron regimen was created in the UK by a dermatologist named Dr. Aaron, who's retired now, but his regimen lives on. It's a compounded mix of a mild topical steroid. Betamethasone valerate is a mid to low potency topical steroid. Topical antibiotic, moisturizing base, either cream or ointment based on your preference. Safe enough and dilute enough. It can be applied anywhere on the body, head to toe, face, eyelids, anywhere it can go. It can be used up to 5 times a day for flare-ups, and it can be used every night at bedtime for prevention and maintenance. So this is something that can be used all of the time and then turned up when you need it. It's safe anywhere on the body. It comes in a 1-pound tub. I don't work for them, but I always prescribe it to Portico because they know it as the Aeron regimen. It's just easier for me. They know the recipe. The 1 pound tub is often not covered by insurance because it's a compound, and a lot of insurances just say no compounds. The 1 pound tub costs $78. They have coupon cards you can get for your office that save patients $10. But the 1 pound tub lasts a really long time. This stuff is magic, especially for kids under the age of 5. Yes, we have a testimonial. Yeah, magic stuff. I've had pediatricians call me like 2 days after I saw a child and be like, oh my gosh, how did you do this? Like, it really is fantastic. I'll show you some before and after pictures. So this is a child treated with the Aeron regimen. This is follow-up at 2 to 3 weeks. And you can see just magical success. And because of its dilute nature, it's appealing to families, even the steroid phobic families. Once I tell them what's in this and how the ingredients break down and that it's 8/9 moisturizer, even the steroid phobic families can get on board with this. And sometimes I'll just prescribe like a 1/4 pound tub, and I'll say, buy the 1/4 pound tub. If you're not convinced by the end of its use, then I agree I'm wrong. But I promise you'll be convinced by the end of that 1/4 pound tube. We also have a new prescription topical in dermatology to treat atopic dermatitis. It's called Opzelura, generic name ruxolitinib. It was approved in October 2021. It is a topical JAK inhibitor for patients with atopic dermatitis who are 12 and older. Twice a day application, no stinging and burning, which is really nice. It's particularly good for tactilely sensitive kids and teenagers and adults that complain with stinging and burning with everything. It appears to have the efficacy and speed of improvement of a topical steroid without being a steroid. It is what we have hoped for decades. It is a very exciting product. It's safe for all body areas, including face and eyelids. Now, there's 2 things that are special about topical ruxolitinib. One, it has a black box warning on it. The reason for that is it is a member of the JAK inhibitor family. And the JAK inhibitor family, we're going to talk about them a little bit more later in the presentation, but it's typically a group of pills. Xeljanz is a JAK inhibitor, and Xeljanz is the reason for the black box warning. It was studied in patients with rheumatoid arthritis who were older than 50 years old, who had to have at least 1 cardiovascular risk factor, and were all on methotrexate as well. In that study, they found some safety concerns that generated the black box warning, and so all JAKs, including this topical medicine, got the black box warning because they are in the same family. How I explain it to patients and their parents, and I do every time because otherwise they'll read about it and you'll get an angry phone call. But I say Opzelura is a little bit like Kendall Jenner. She's low drama, but she's in the same family as Kim and Khloe and Kylie and Kourtney, higher drama. And that seems to resonate with everybody. They immediately understand. The other thing that's special about Opzelura is that it's indicated to treat up to 20% BSA. The size of your hand is 1%. So this can treat up to 20 hands of skin that has eczema on it. Recently approved oral JAK inhibitors for atopic dermatitis. We have Rinvoq and we have Cibinqo. Both are now approved 12 and up. Rinvoq came out the gates from the FDA with a 12 and up indication. Cibinqo just last week was modified to 12 and up. These medicines work super fast, especially for itch. And they're a pill, they're both a once daily pill. 3 things that are important with these JAK inhibitors. Number 1, there's an increased risk of viruses, specifically cold sore virus and shingles. And so I'll talk to patients if they've had a history of cold sore virus. I'll talk about suppression. If they are at an age where they can get vaccinated for shingles, I will encourage that, or at least tell them they're at increased risk. So call me if it happens, one-sided rash, that sort of thing. There are labs required with these JAK inhibitors. We have to screen for hepatitis B and C and a quantiferon gold at the beginning, and then we have to do regular monitoring of CBC, CMP, and lipid panel. There's the black box warning, of course, on these medicines too, because these are the pills. And the black box warning, of course, is based on the Xeljanz study, which again, very different patient population. Patients older than 50 with rheumatoid arthritis, with 1 cardiovascular risk factor, all of them on methotrexate, and 57% of them also on prednisone. So this is not your general atopic dermatitis eczema patient population, and we are not seeing the safety signals that they observed in the Xeljanz study in our patient populations using Rinvoq and Cibinqo. And these medicines are too awesome to not use. They really work well and work fast. Dupixent. So Dupixent has been out for almost 6 years. It's turning 6 next month. How many of you guys have had a patient on Dupixent? How many of you guys have seen a person's life changed because of Dupixent? Yeah, it's phenomenal. This medicine revolutionized everything. So it inhibits IL-4 and IL-13, those two cytokines I told you about. It's incredibly safe. The two most common side effects, injection site reactions and conjunctivitis. You don't have to do any labs for this medication. It does not suppress the immune system. There's no boxed warning, and it's approved down to the age of 6 months. Imagine that, like there are topical medicines that are not approved down to the age of 6 months, and here we have this shot, this biologic approved down to the age of 6 months. This medicine is fantastic. The only downside to it is that it's a shot, and that can be a hard sell to some patients. The dose of it is either every 2 weeks or every 4 weeks based on your age and weight. But this is what this medicine does. This is after 3 shots of Dupixent, before and after, before and after. This child, you guys, was 7 years old. Does he look 7? No, because of the growth restriction that we see in patients with bad atopic dermatitis. I often joke that picking a systemic agent to treat bad atopic dermatitis before we had Dupixent was like picking a porta potty out of a row of porta potties. You know they're all gonna suck, but you've gotta pick one when you have to go. I was never excited to put a patient on methotrexate or cyclosporin for their atopic dermatitis. I did it out of desperation. I had nothing else to help them with. And now it's so nice that we don't have to pick the porta potties anymore. And the kids, I'm honest with them about the shot. It's a shot and it hurts. And it hurts for 2 or 3 seconds, but it's worth it. And I tell them, you're not gonna like the shots, but you're gonna like being able to sleep. You're gonna like not being itchy. You're gonna like not having bloody sheets. You're gonna be like being able to wear the cool clothes that you like, and you're gonna like being able to go to school. And that 2 to 3 seconds of ouch every, once or twice a month is gonna make you feel better all of the other seconds of all of the other days. And I tell the families, this is turning the eczema into something that you guys have to think about once or twice a month, rather than every day, all the time with these topical creams. Not all kids are convinced when I break it down for them. This is Jackson. This is the day he got his first Dupixent shot. He had horrible atopic dermatitis. And I told him, I'm like, yeah, bud, it's gonna hurt, but it's gonna be worth it, I promise. And so we go ahead, we give him the shot. Of course he cried, but we have a cool prize box and he got over it. Next time he comes back in a month later and his mom says, we have had our first month of peace since my child was born. I don't care if he cries, we're doing this. So we go ahead and give him the second shot, and he was nervous, but he actually didn't even cry. Third shot, he came in, he got his shot, and he turned to my MA Tony and said, thank you, Tony. Thank you for giving me my shot. Even at 5 years old, Jackson's 5, even at 5, he understood this medicine was making him feel better, and he liked that. The feedback you get from parents of people on Dupixent will make your day. I would like to frame them all. The most common thing is, I feel like I'm meeting my kid for the first time. They've been so tethered by the atopic dermatitis that they haven't been able to fully live their lives. This is wonderful. So I tear up a little, and then I tear up a lot whenever I think about my patients on Dupixent, because it really is revolutionary. It's great. Other future treatment options. So we've got Adbry, which is an IL-13 inhibitor, also a shot. We have lebrikizumab, which is coming soon, IL-13 inhibitor coming soon. We have new topicals that are non-steroids that are coming soon, which we're very excited about, new topical non-steroidals. So now we'll move on to psoriasis. So classic psoriasis is on the elbows, knees, and scalp, presents with these thick red plaques with silvery scale. In kids, the plaques tend to be thinner, less scaly, and more pink than red, and so it commonly gets misdiagnosed. The incidence of pediatric psoriasis is skyrocketing. When I first started in practice 12 and a half years ago, I would see 1 new patient a month with pediatric psoriasis. Nowadays, and for the past 5-6 years, it's been 1 new patient every day, 1 new diagnosis every day of pediatric psoriasis. Nobody knows why. A lot of people initially suspected it was the American diet. So they did a worldwide study looking at incidence of pediatric psoriasis. It's happening everywhere. So we can't blame our American diet. So pediatric psoriasis is going to cross your path if you see kids. So this is classic psoriasis. One of the hallmarks of psoriasis, if you're trying to differentiate from psoriasis from eczema, is psoriasis is well demarcated. You can take a pen and circle the patch, whereas eczema, poorly demarcated. It would be harder to take a pen and circle the patch. It's very common on the face in kids, psoriasis is, whereas in adults, we don't tend to see psoriasis on the face. Guttate psoriasis is a special type of psoriasis that typically occurs in children and is typically triggered by strep throat. Guttate means teardrops, so it produces these little teardrops of psoriasis, and I'll show you pictures. It's often confused with pityriasis rosea. Check the fingernails, check the belly button, check the tongue, check the gluteal cleft. These are areas where you can get clues to differentiate guttate psoriasis from pityriasis rosea. Biopsy is never helpful. I fell for that earlier in my career. So sometimes I'll tell people, let's wait it out. PR should be gone within 8 weeks. Let's see if it's still there after 8 weeks. This is a picture of guttate psoriasis. You can see the classic psoriasis pink that actually does project very nicely, and belly button involvement. Psoriasis loves the belly button. If you see a rash involving the belly button, that is psoriasis until proven otherwise. This is a picture of pityriasis rosea with the Herald patch and the other little patches. One of the key defining features of PR is this thin epidermal collarette on the inner outer border of the PR lesion, which you can see hopefully in these projections, that little hint of scale along the inner outer border. Pityriasis rosea, as we know, triggered by a virus, runs its course. I got PR 2 years ago. It was spring 2021. I was about to go in 3 weeks' time on my first vacation since COVID to Hawaii, and I broke out in pityriasis rosea. And I was like, I'm too old for PR. You know, I'm in my 40s. That's too old. You should be too old. And so it was really a bummer. So I had to go to Hawaii with a rash. But that's okay, because I'm a dermatologist, and so I'm covered up anyway, so everything is cool. So back to psoriasis. We also see psoriasis in the folds. We see psoriasis in the armpits and in the groin area, presenting as these thin, pink, moist appearing patches without scale, because these are moisture locations. Again, very well demarcated. This is almost always mistaken for yeast. So if you ever are treating a patient with a persistent rash in the underwear area that you have thrown everything yeast related at, and it hasn't worked, you're looking at inverse psoriasis, my friends, and you can send it to us or you can treat it. Inverse psoriasis responds nicely to the topical calcineurin inhibitors like Elidel and tacrolimus. It works like wonders for inverse psoriasis. Palmoplantar psoriasis can mimic dyshidrotic eczema and involves the palms and soles, but again, very well demarcated. You can see in this picture, you could very clearly take a pen and circle the areas of involvement. TNF inhibitor-induced psoriasis, so we use TNF inhibitors to treat psoriasis, but sometimes we get a paradoxical psoriasis from the TNF-alpha inhibitor. Go figure. The most common culprit is Remicade. Second most common culprit is Humira. And so these are patients who are started on these drugs for inflammatory bowel disease or inflammatory arthritis, and then lo and behold, they get psoriasis. 1/3 of patients, if the TNF inhibitor is stopped, it will just magically go away, but the other 2/3 just have psoriasis now. If the TNF inhibitor is working for their primary disease, I will treat the psoriasis and you know, they can stay on their TNF. But if it's not working, then I would encourage a switch. Psoriasis eczema overlap is something we see commonly in kids. This is where in one part of the body it really looks like psoriasis, and in another part of the body it really looks like eczema. And you're like, how on earth is this happening? Eczema is a Th2 inflammatory disorder. Psoriasis is Th1. How are these two things occurring simultaneously? But it happens all the time, particularly in our pediatric patient population. So look for clues. Look for signs like the Kebner phenomenon. Psoriasis likes to pop up in areas where the skin has been traumatized. I once saw a adult female come in for psoriasis. She had gotten her eyebrows waxed. She had no history of psoriasis that she knew about. She got her eyebrows waxed, and then she got psoriasis in the exact distribution of the eyebrow waxing. Oh, I know. And so, you know, what a bummer. And so you can look for the Kebner phenomenon in kids because they're always falling down and skinning their knee or doing something like that. And so look for features of the Kebner phenomenon to help give you clues. These are pictures of the same patient, very psoriasiform on the back, very eczema-like on the arms and legs. For kids with eczema psoriasis overlap, we treat them with topicals because the topicals are largely the same, and we see what happens over time. Do they outgrow it and it was just eczema, or does it declare itself as psoriasis down the road? Clues to psoriasis, some of which I've alluded to. This is geographic tongue, so I always check the tongue for a clue. Belly button involvement, psoriasis loves the belly button. Gluteal cleft involvement, this is pretty big deal here. A lot of times it's just like pinkness in the gluteal cleft. And so if I'm seeing a patient with eczema psoriasis overlap, I'm like, hey, can I look at your tongue? Can I check your fingernails? Can I see your belly button? And then I'm like, can I look at your butt crack? And the kid's like, oh, I don't know. What's this lady wanting to do? I don't know. So this was texted to me. This picture was texted to me with no other information from a family medicine doc back in Colorado. He had meant to include more information, but just had gotten busy and hadn't. But I was able to look at this and say, this is guttate psoriasis. Because first of all, it's psoriasis pink. If this were a crayon, this would be called psoriasis pink. And second of all, you can very clearly see the Kebner phenomenon. There was a scratch and psoriasis popped up all along there. So you can be confident in that diagnosis. Check the nails for pitting. The pictures on the left is very subtle. The picture on the right, very prominent. If you have severe nail psoriasis, you're at increased risk for psoriatic arthritis. It's like a window to the joints. So those patients need to be evaluated special. Psoriasis treatment has largely been topical over the years, especially in the pediatric patient population. You typically have to use a strong topical steroid for areas on the body. You can use the topical calcineurin inhibitors for face and groin area, clobetasol in a foam or solution for the scalp. I don't love Dovanex or Tazorac on its own, but there are a couple cool combo products where they combine a steroid and a non-steroid. We also had 2 new non-steroid topicals for psoriasis, and both of these medicines are going to come out for atopic dermatitis too. So that'll be really exciting. So we have Vitama, approved 18 and up, once a day. Most common side effect was folliculitis in the area that it was applied. And then we have Zoryve, approved age 12 and up, once daily, non-steroid, no side effects to really tell people about. So very exciting developments. When I diagnose a person with psoriasis, I tell them it's a great time to have psoriasis because I have more tools in my toolbox than ever before, so we can really help you. Psoriasis, as we've learned, is a systemic disease with systemic implications. That inflammation that's causing the skin rash is not just in the skin, it's everywhere. And it's wreaking havoc on the patient's general health in the future. So in kids, there's even testing guidelines to monitor for these side effects. And in adults, it's even more significant and even more of a concern. And so these are things you have to think about in your psoriasis patients. They are at risk for multiple other things. And the burden of illness is really significant, especially when it's a child. There's the cost of the medications, the cost of the visit. There's dealing with just having the heartbreak of psoriasis. And whereas I can tell patients with atopic dermatitis, there's a good chance you're going to outgrow this, you can't say that to a psoriasis patient. They tend to not outgrow it. That doesn't mean they're always going to have it. There can be years where they're in a state of remission, but they're never going to just outgrow it and never have it again. The incidence of comorbidities in kids with psoriasis is twice that of kids who don't have psoriasis, and so this is something to be taken seriously. However, it's a good time to have psoriasis because we have all these therapies available. This is a list of our systemic therapies to treat psoriasis. So we have several biologics, and we even have a couple of pills. All of these medicines are wonderful, safe. Sometimes it's hard to choose. I feel like I'm the bachelor trying to pick a bachelorette, you know? It's just so many options. I just don't know which one is right for me. And so there's a lot to choose from. Anybody suffering with psoriasis should come see a dermatologist because we can really make it better. We even have 4 biologics approved in the pediatric patient population, and the drive to treat these patients with systemics is increasing because we know it's a systemic disease. And so if you think about it as a systemic disease, wouldn't it be better to treat systemically? My favorite for kids is Stelara. This is Lauren. So Lauren changed my life. She was a Colorado patient, as you can tell from her t-shirt. But Lauren was 9 years old, and she had horrible, horrible psoriasis. And we had done everything. We had done topicals up the wazoo. They had a home light unit at home, and she just still really, really struggled. And so I was about to break into a conversation about methotrexate and cyclosporin. And in my Denver practice, I saw some adults too, and I had just seen some adult patients on Stelara and Humira. And in my head, I just had this epiphany. Why on earth am I about to offer what's quickly becoming substandard treatment to this patient purely because of her age? And in that moment, I decided I was going to tell her about Stelara and I was going to tell her about Enbrel because they had some pediatric data at that time, in addition to methotrexate and cyclosporin. But as soon as I talked about Stelara, Lauren herself was like, that's the one I want. Can I get my shot today? And when I left Colorado, she was still on the therapy, still doing wonderfully. Stelara is my choice for young kids because it's just one shot every 3 months. It's very easy and it's very safe. As I mentioned before, psoriasis is a systemic disease, and we think if we treat systemically, we can thwart the psoriatic march of inflammation that occurs in these patients. And we have 2 studies now that show that our hypothesis is likely correct. One was using Stelara, where they looked at PET-CT and they looked at inflammation in various parts of the body, specifically the aortic root. Apparently that's indicative of cardiovascular disease risk. And they found in 10 patients, so small number, but 10 patients, in a year of Stelara, it reduced the inflammation in the aortic root by 19%. So extrapolate that over time. We can help reduce this systemic inflammatory process. For Humira, they did a study looking at patients on Humira over 10 years. And they looked at all-cause mortality. So they said over this 10 years, odds would be that 144 deaths would occur in this patient population of over 6,000. And they found only 60 people died. And the tagline of the article is, you can save lives by treating psoriasis. And I think that's very true. The impact of pediatric psoriasis on the parents is a really big deal. Increased risks of anxiety, depression, they worry all the time. This was a lesson taught to me by Addison and her mom. Addison had probably mild to moderate psoriasis, and one day they were there for follow-up, and Mom said, "Can I talk to you alone?" And I said, "Sure, Addison, go pick out prizes from the prize box." And she broke down in tears with all her concerns over Addison and her future and her psoriasis. And in that moment, we decided, okay, we're going to do Stelara for Addison, and this was the letter she sent me afterwards. Everybody's happy. Addison's happy, Mom is happy, I'm happy, everybody is happy. I wanted to update you guys on an exciting development in the world of vitiligo. So Opzelura, that topical JAK inhibitor I told you about for atopic dermatitis, it's also approved to treat vitiligo for patients age 12 and up, and it works wonderfully on sun-exposed areas, especially the face. Anybody you know with vitiligo on their face needs to come to see a dermatologist next week and get prescribed Opzelura. I'm telling you guys, and I'll show you guys, it works amazing. It's applied twice a day. And I always encourage patients to also take an over-the-counter supplement called HelioCare. So Opzelura works better with sunlight. HelioCare is used for a lot of different things, but one of its strengths is that it makes light therapy work better. So if you're doing light therapy for vitiligo, you need fewer treatments, you get better faster. So I kind of build upon the successes of both of those and have people take HelioCare daily. It's an over-the-counter supplement based on a fern leaf extract from South and Central America. You can get it on Amazon. You can find it at Walgreens sometimes. Very safe. It also works fantastic for sun-sensitive skin disorders like polymorphous light eruption, rosacea, lupus, dermatomyositis, anything sun-sensitive, HelioCare is really awesome treatment for. So this is an 8-year-old with segmental vitiligo on his left cheek, and we decided to start Opzelura. And yes, I just told you it's approved 12 and up, so I used samples because it was a small area. I was like, I think we can get by with samples. And so this is him at baseline, at 2 months, and at 5 months. And I asked him, I was like, why so glum, chum? Like, your vitiligo is getting better, but you look like you're getting sadder as these pictures go on over time. And he said, no. He said, it has to do with the timing of the appointments. I'm not a morning person. And I was like, okay, I'm glad. This is a female who, her daughters were coming to see me. And I happened to notice that she had vitiligo on her face. And again, anybody with vitiligo on their face needs to come see a dermatologist next week and get a prescription for Opzelura. And so I said, I noticed that you deal with vitiligo on your face. And she broke down into tears. It was devastating for her. She had no self-esteem. She was really feeling awful about it. And she was so grateful that I asked. You can see in her face just how she feels about this. And so I said, no problema. Let's go ahead and prescribe Opzelura. You take the HelioCare daily. Let's see you back in 3 months. And this is her when I saw her earlier this week, you guys. She said, you gave me my face back. You gave me my life back. Vitiligo is really burdensome to patients experiencing it, especially on their face, and now we have a wonderful treatment for it. Acne updates. Toddler acne is different than baby acne. So toddler acne starts between the ages of 6 months and 18 months of age. It can even scar. So this is an important subset of acne to recognize in an 18-month to 3-year-old child. And this is a picture of a child who had toddler acne and it left behind some scarring there. So this is what we want to do. We want to treat it. We typically start with clindamycin and then we get fancier if we need to. But the most important point I want to drive home is that toddler acne is not the same as baby acne and should be treated. Mid-childhood acne, acne that develops between the ages of 3 and 7, is abnormal and should be worked up with this list of labs or with a referral to a pediatric endocrinologist. It can also sometimes be due to inhaled steroid use, so ask about that before you get out the lab slip. But this is a type of acne that is considered abnormal. Acne before the age of 9 used to be considered abnormal, and now it's before the age of 7. Puberty is happening younger, acne is happening younger, but acne between 3 and 7 is abnormal. We have a couple new topicals in the world of treating acne. We have a topical minocycline foam, which works really well. It's a nice product. It's approved down to age 9. It has a nice feel to it, but the foam is bright yellow. And so it will get yellow on your pillowcases, your t-shirts, if you're using it on chest and back. Just important to tell people that. The company says that it washes out, but I've had a couple patients tell me it didn't. And then clascoterone, under the brand name Winlevi, is a new topical anti-androgen. Think about like spironolactone, but in a topical. It's applied twice a day. Very effective therapy, very tolerable therapy. Birth control pills. So in general, we are desiring to avoid oral antibiotics to treat acne. We would always like to do something different. When we do oral antibiotics, we'll do them for 2 months, and we always also use a topical regimen because we're only doing the oral antibiotics for 2 months. We're going to need something to take us through after that. And so we're thinking about other options. We're thinking about birth control pills. We're thinking about spironolactone. We're thinking about Accutane. So I wanted to talk to you guys about that. We know birth control pills help. It turns out that the non-estrogen component matters for efficacy, with drospirenone being the most effective, and then these others being second best, and then third best. I think the birth control pill that's best for the patient is the one they tolerate the best in general. But we do know Yaz and Yasmin work particularly well for acne. We also know that there's been controversy regarding increased risk of DVT-PE when it comes to these Yaz and Yasmins. There was an awesome article that you guys are probably familiar with. I love the title, "Pregnancy is More Dangerous Than the Pill, a critical analysis of professional responses to the Yaz-Yasmin controversy." And this article broke it down in terms that I can understand and relate to my patients. So the risk of venous thromboembolism, just being a woman, is 3 out of 10,000 woman years. Being on a conventional OCP is 6 out of 10,000. Being on Yaz or Yasmin is 9. Being pregnant, 15 to 20. Being postpartum, 40 to 65. So you can break that down with your patients if they're concerned about that. Spironolactone, we're using a lot more of this in our female patients to treat acne. Historically, it's been used in the patients who are in their 20s, 30s, 40s, but now we're using it for teenagers too. It's also quite helpful for acne due to an IUD, Implanon, or Depo shot. We haven't had as much data in teens, but I've used it quite a bit and it seems to work quite well. We always start with 50 milligrams. We can go up after that. And you only need to worry about labs if you're using a dose higher than 200 milligrams, which we really only use for androgenetic alopecia. We don't use doses that high for acne. Accutane. Accutane, wonderful medicine. This is a pill that you take for 5 to 6 months. It works 100% of the time to clear up 100% of the acne. And for 85% of the people who take it, it is a permanent fix. Think of another thing in medicine that works 100% of the time and is a permanent cure 85% of the time. This medicine's amazing. And it's natural because it's a derivative of vitamin A. So I like to throw that out there. I don't talk about Accutane because I'm encouraging you guys to prescribe it. The iPledge program is a royal pain and not many primary care providers do it, and I think that's fine. But I want you to know a little bit about Accutane so that you can talk about it to your patients that need Accutane, and so that you don't say anything too bad about Accutane, because it can be frustrating if I see a patient that really, really needs Accutane and maybe their pediatrician has said something bad about it, and that's a tricky area for me to be in because I don't want to say that the pediatrician was wrong or anything like that. So if you don't have anything nice to say about Accutane, don't say anything at all. But these are the counseling things that I tell my patients. It's going to make you dry. Some people get achy. We have to do labs. We'll talk about all this actually. So I'm going to speed up a little bit. Horrendous birth defects if a woman gets pregnant on it. And so that's why we have the I Pledge program, and you have to choose a form of pregnancy prevention, but abstinence counts. That's another misconception. Abstinence counts. You don't have to be on a birth control pill. And there's no risk to children of the males on Accutane ever. We now know that we just have to do labs for Accutane twice, and we just have to do ALT and triglycerides. So lab monitoring is easier. Accutane does not cause inflammatory bowel disease. Accutane has been acquitted of all guilt when it comes to inflammatory bowel disease. Accutane is getting close to acquittal with depression. The studies that have been done, which are really large studies using tens of thousands of teenagers, show no association between Accutane and depression. In fact, most patients in these studies showed an improvement in their mood because their acne got better and their self-esteem improved and their confidence improved and they felt better. But I have had 6 patients total in 12 and a half years of prescribing Accutane every single day, multiple times a day. I have had 6 patients become depressed and have to stop. And all of them were either cutting or suicidal. It was a very real thing. It is incredibly unpredictable who those people are going to be. One of them was a twin girl. Both the girls, they're identical twin girls, both of them on Accutane. One of them jumped off a ladder head first. The other one completed her course no problem. It is so weird. And so I think these episodes of it are so small and rare that they don't pop up in the studies on tens of thousands of teenagers. I do think there's a real thing here, but I think it's rare. And when you stop the medicine, it goes away. So some rapid fire pediatric dermatology and applicable to adults. Warts. Are you guys ready to have your life changed? The most magical treatment for warts is called Wart Peel. It is a compounded medicine made by a pharmacy in Iowa called Nucara. It is mailed to the patient's house. It is applied every night at bedtime. It comes with sticky tape to put on top of it. You do it every night until your warts are gone. Typically takes 3 to 4 weeks, you guys. It doesn't hurt and it works 98% of the time. This stuff is magic. This is all I do for warts. And believe me, I see warts all day, every day. It's a combination of salicylic acid and 5-FU. It's mixed in a proprietary medium. They have a patent on this. In fact, they have 2 patents on this. Other compounding pharmacies will make something similar and they often charge less, but they don't work as well as Wart Peel. The Nucara pharmacy mails it straight to the patient's house. They don't deal with insurance. It costs $99. It is worth every penny, you guys. One visit to see you is $99 at least. And so if they're having to come back in for freezings and stuff like that, Wart Peel, 98% effective. Quick comment on ring phenomenon, and then I'll show you before and after pictures from Wart Peel. If you treat a wart with beetle juice or liquid nitrogen, it can cause the ring phenomenon where you get a ring of warts around the initial wart. Very important to recognize this and not continue the beetle juice or liquid nitrogen. It will perpetuate the ring. This is a before and after for Wart Peel. You see June 10th, June 25th, you guys, 2 weeks. Great around the nail, works amazing, heals beautifully. It's awesome. Molluscum, bane of my existence. You know, there was an interesting study where they took 170 kids, they treated half of them, they didn't treat half of them, and they all went away in the same amount of time. And sometimes I'll share that with patients and their families, and the parent looks at me with a blank face and says, "Oh, but we're gonna treat them, right?" Yes, of course we are, of course we are. And I discuss these options with them. I'm cool with you guys not treating molluscum. You guys have a lot of things on your plate. You can let molluscum go. And if people want to treat them, they can come see me and I'll go through that joyful time with them. Interestingly enough, Zymoderm is a natural option that I often tell people about. And while patients are so interested in natural options for their eczema, nobody chooses it for the molluscum. These parents, they want like the most corrosive, most like biggest deal thing to get rid of the molluscum. I think if I phrased it correctly, I could advertise anthrax as a treatment for molluscum. Like, you just dab a little anthrax on it. It'll work like a charm. Well, do you think it'll work? Yeah, I think it will. Yeah. You'll also have like a non-healing ulcer, but like it'll work. It'll get the molluscum gone. We have 2 molluscum treatment options on the horizon that are going to get officially FDA approved. Right now, we don't have an official FDA approved option to treat molluscum. All those things on my previous slide, those are off label, but we're about to get 2 topical things officially approved. Important factors with molluscum: pseudofurunculoid molluscum are molluscum that look like boils. Do not drain them. They are a positive sign of immune system response. We call it the boat sign, meaning beginning of the end. Molluscum dermatitis is eczema around the molluscum. Important to treat that too because it's itchy, so kids scratch and that spreads the molluscum. There's a misconception that putting topical steroids near a molluscum spreads the molluscum. That's not true. Not treating the molluscum dermatitis spreads the molluscum. These are pictures of pseudofurunculoid molluscum. Again, don't drain them. They're fine. This is a child with a lot of pseudofurunculoid molluscum, so much so it triggered an id reaction. An id reaction consists of skin-colored to pink monomorphic papules all over the arms, legs, and cheeks, and it's an exaggerated response of the immune system to something. We see it with molluscum, we see it with tinea, ringworm, and we see it with contact dermatitis that has been going on for a long time. For patients who have this, you want to treat the pseudofurunculoid molluscum with oral antibiotics or bleach baths for their anti-inflammatory properties, not their antibacterial ones, and treat the id reaction with topical steroids, and then it's all better. Again, molluscum dermatitis, treat it, use some topical steroids to treat it. Eclipse nevi are two-toned nevi on the scalp of children, particularly blonde-haired children. And they either have a dark center with a lighter rim or light center, dark rim. These are completely 100% normal and can be left alone. Do not biopsy them. They are A-OK. Where there's one, there's often several. Don't be surprised to see more. And you don't need to touch them. Always give a teenage boy a snack after any sort of needle or procedure has been used. These boys will hit the ground faster than a sack of potatoes, and it never happens in the room. It happens in the waiting room or in the parking lot as they leave. So years ago, I instituted a mandatory snack policy for all teenage boys having biopsies, and I haven't had a single teenage boy pass out. I wanted to turn back to Lauren. So Lauren had been on Stelara for a year, and they came in for her shot, gave her shot, and then Mom and Lauren left, and Dad kind of hung back. And he said, I wanted to let you know that you have had a profound impact on all of our lives. And we appreciate you and we thank you. And we're so grateful that you came into our lives. And as my eyes filled with tears, I thought two things. I hope they leave a positive review on Yelp. Because that would really help my average. And number two, this is why we do it, you guys. This is why we're in medicine. This is why we're here to fix things, and it's my passion for pediatric dermatology that keeps me going, and I'm thrilled to be here talking to you guys about it today. This is my email address again. Please email me. I'd love to help you out with a pediatric derm issue. These are my doggies. This is my family. And I wanted to put in a plug for tomorrow night's dinner. You're going to hear a lot more stories from me about a lot more stuff. It's a burnout talk, but it's going to be fun, you guys. You'll laugh, you'll cry, you'll feel better, and you'll get a delicious dinner. So come to the dinner tomorrow night. And that's it. That's my talk. Thank you. And
All right, we've got a few minutes for questions. So does anybody have any questions? And I'll put the microphone right over to you.
I actually have two questions.
Yeah.
The first one is there a antibacterial product recommended for wrestlers?
Don't wrestle. Yeah, when I see wrestlers, I say, you and I are going to be good friends because I'm going to take you through molluscum, warts, staph, fungus, HSV. They're going to get it all. I don't think there's a way to keep them safe. Yeah.
Bubble wrap. Okay.
Yeah, bubble wrap. Yeah, they should wrestle in like saran wrap or bubble wrap. Yeah.
Okay. And then my other question, is there a location of molluscum that makes you more likely to treat, like on the face or sensitive areas, or just all the same?
No, every patient I see with molluscum, I say, these will eventually go away on their own. It is not mandatory to treat. There are treatment options available if you'd like, but it is okay to just leave them alone. But most of the patients coming to see me are coming to see me because they want treatment. Their primary care doctor has told them you don't have to treat them. They're not taking that as an answer. And so they're coming to me because I will treat them. So it's always okay to leave them alone. There's never a reason where I'm like, oh my gosh, we must treat these molluscum. Those words have never come out of my mouth. Yeah.
Does molluscum frequently lead to some sort of eczema and then it gets infected, you have a secondary problem though?
Good question. So kids with eczema get molluscum worse. And it could even be like a history of eczema. But they're going to get molluscum worse. They're going to get more of them. It's going to get bad. And we think it's the impaired skin barrier allowing the virus to kind of have a field day. And so you can expect a tougher course with a patient with an eczema history. It's always important to manage the dermatitis eczema part of it because that's a real thing that's driving it. Kids with eczema are more at risk for infection anyway. But even in a child with eczema, if you're seeing those pseudofurunculoid molluscum, they're not infected, they're inflamed.
I have a couple of questions going back to the atopic dermatitis. The NICU stage, is that predominantly from the humidified isolate, and is that what the driving force was that, or do they feel like it's something else?
The leading theory is that it all boils down to flora, that all of it boils down to flora on the skin and in the GI tract. And so in the NICU, you have so much flora going on. And so it's somewhat protective, so maybe the staff doesn't get overgrown. But these are all pieces to a puzzle that we don't know the full picture yet. But it's leading us towards something. Yeah.
And my second question was around the probiotic recommendations. So a lot of the data for probiotics is centered around GI and surgical C. diff and ICUs, and Culturelle and Kiefer were the two recommended probiotic units out of most studies. So do you have recommendations for your atopic dermatitis?
So I had always recommended natron because there was a speaker at a meeting at our Peds Derm conference that recommended natron. And then we have a new PA at our practice that comes to us from GI, and she thinks Florastor is the best. So I'll tell people natron or Florastor.
Any other questions? That one back.
Mm-hmm.
Just like a logistical thing about the wart treatment, because of course we see those a lot. And for $99, I guess I was thinking like, well, if somebody just has one small one, I probably feel pretty good that maybe they have several, might try this. Can you order that in like an EMR?
Yes. Yeah. So the pharmacy is New Cara. It's in our EMRs, but we use something called Emma, which is different. So I don't know if it's in like Epic and stuff like that. It is technically orderable in an EMR. I'm just not sure if it's orderable in your EMR, but you can also call it in and you can also fax it in. If you Google New Cara wart peel, they have sheets you can print out that are a patient information sheet and a prescriber sheet.
Okay, that's kind of probably has the stuff about this too. I was just going to ask about that, like you tell them a certain time to buy.
It comes with it. Everything you need comes with it. Yeah. And let's say a patient has like 30 warts. You actually don't need to put the wart peel on all of them. You can pick the worst ones that you hate the most. And there's an ingredient called 5-FU in there that'll trigger an immune system response. So you can just treat a few and have them all magically go away. Yeah, it's pretty cool to see. Yeah, you're in. Or oh, so sorry.
Oh, just real quick,
Yeah.
Aeron
Yeah.
regimen, is there a youngest age you'll start?
Day 1 of life.
Wow.
Yeah. Even day 0. I would do day 0.
You don't have to do like 2 weeks on, 1 week off?
No, nope, nope. In that 454 gram tub, 30 grams of it is a mid to low potency topical steroid. But the combination is magic. Yeah.
My question, maybe you just answered, I was distracted there. Is there a duration that you need to?
No.
Okay.
Yeah.
Definite.
Yeah. Yeah. I do a 1 pound tub. I do 3 refills. I'll see them back at a month, or 3 to 4 weeks, just to make sure all is cool. And then I do either like a 6-month follow-up or a yearly follow-up.
I see a lot of patients with joint pains and history of psoriasis. Are dermatologists equipped to evaluate that, and our rheumatology community is difficult to access?
Right.
Lately, so could you comment on that?
I think a dermatologist is reluctant to label a patient with psoriatic arthritis, but we certainly know which of our biologics work the best for psoriatic arthritis. And so we could start them on a therapy that's going to help with their joints and see a rheumatologist in 6 to 12 months.
Is that based on the degree of their psoriasis or based on joint pain as
Joint pain as well. Some of our biologics on that list I showed are particularly good at psoriatic arthritis. And so we would choose that if we were suspicious.
Winlevi is really expensive and never covered. Is there any info on maybe compounding spironolactone?
There are pharmacies in town that compound spironolactone. I've never found it to be effective. And clascoterone, while people call it a topical spironolactone, is not exactly the same as spironolactone. A little trick, all of us dermatologists, we send any brand name medicine to Timberline Pharmacy. I'm not affiliated with them, but they're a dermatology pharmacy and they have all the coupons. And like Winlevi's $30 and Amzeek's $50, even if insurance doesn't cover it. And like the new psoriasis topicals, Vitamas or Reeve, those are like $35. So anything brand name that's dermatologic, I would recommend sending the prescription to Timberline. It's off 10 Mile. People can pick it up, but they also do free home delivery. Yeah.
All right, that was an excellent talk. Let's give Dr. Swanson a big round of applause.